The world of repurposed cancer medications or off-label is actually a very broad amount of drugs. The first thing you want to think about with repurposed drugs is there are multiple categories. So there's the antiparasitics that are the most famous and hot right now that we'll talk about. There are the anti-diabetes drugs, kind of touched on those. There are drugs such as certain blood pressure medications can be anti-cancer, certain antiviral drugs, statins for cholesterol can be anti-cancer. And then in addition to the antiparasitics, there's a number of antifungal drugs. Now the menu is much broader. So I've been doing this way before it was cool, before social media. So what's interesting is...
All right. Thank you so much for joining me today. I'm just going to give a little short introduction on Dr. Paul Anderson, who is kind of a guru in natural functional medicine and in medicine in general, I'd say. But I'm just going to read straight from what I've got written because I don't think I could do any better than this. But basically, Dr. Paul Anderson, he's here. He spent over 3 decades working at the intersection of integrative medicine, complex chronic illness, and cancer, including leading NIH-funded human research and teaching at multiple medical schools. His work focuses on helping clinicians think more clearly about how therapies actually interact in the body. He's the co-author of 3 books that I highly, highly, highly recommend that you guys go check out. I'll link them into our show notes and I'll let you know where to find them in the podcast episode as well. And without sounding too blasphemous, I do consider that your book, The Outside the Box Cancer Therapies, to be kind of like one of the Bibles of integrative medicine. I've read it many times and referred back to it many times. But Dr. A also has an amazing YouTube channel, which also feeds into his online continuing education website for clinicians, consultdra.com. And he spends most of his time on a plane flying to and from conferences as he is an amazing educator, researcher, and highly sought after presenter. So thank you so much for being here today.
Well,
Don't blush too much.
That's great.
We're really going to talk today about off-label drugs and medications. I'm sure this is something that you come across quite often as practitioners asking you questions. I get this a lot as clients ask us questions about basically what is the role of off-label medications. And we could probably spend days talking about them. Today, we're going to focus on GLP-1s and antiparasitics. So we're going to just start with GLP-1s. Why don't you start by giving us some information on kind of like, what are these? What are GLP-1s? What are people coming across when they hear certain names of GLP-1s?
Yeah, I mean, that's probably a great place to start. And I think everything we're going to talk about today is, number one, it's very good, positive, and kind of exciting that we're able to talk about these things in relationship to cancer, whether it's treatment or prevention or what their possibilities are. And I think that, like all things in that sphere, you also have to weigh that against what are all the other things that go on around the way that drug works or the ways it works that we also want to attend to make, give you the best chance of having that be something positive. And I think GLP-1s are probably the newer drugs to the discussion. So in modern times, you might hear of like Ozempic or Mounjaro, Wegovy, Zepbound, stuff like that. They're really marketing very hard right now the move towards oral versions of these drugs. So right now you have to inject them subcutaneously, just like insulin with a tiny, tiny little needle, no big deal. I mean, needles are a big deal to some folks, but I mean, it's the smallest needle you can possibly use. And I talked to, I have colleagues all over the world. One of them is big in the GLP-1 scientific world. And I contacted them just a week ago and I said, what do you think about the move to oral kind of GLP-1s? And they said, the first ones that come out are going to be, have certain side effects, but some people like that more than the injection. They're going to work kind of the same way. But he says in about a year, there will be newer versions that will work even better and maybe even on par with the injectables. And I think that's an important thing to consider because in the weight loss sphere with GLP-1s, they're, the marketing pushes towards orals. Obviously, you get more people want an oral drug that doesn't need needles. Um, People will ask, why is it that you have to inject it? And it's a lot like the story with insulin. It's too big. These are big lumbering molecules. And if you take them by mouth, unless they're prepared a certain way, your digestive system would break the molecule apart and you don't get much out of it. So, just so people know kind of what's coming down the pike there. Um, if you look at the science around the GLP-1 type drug approach, and so it's glucagon-like peptide receptor agonists. That's the long name for these drugs. Um, so glucagon is a peptide in your body that, and so insulin's also a peptide. And so when your body is working, there's always a dynamic balance between insulin and glucagon. And so whenever insulin is really active, glucagon gets less active. When glucagon gets more active, insulin gets less active.
Mhm.
So back in the olden days when I used to be a pharmacology professor, um, I started to teach about the original versions of these drugs that were just these very kind of marginalized drugs used in diabetes that wasn't getting under control. And I would talk to patients and they would say, you know, what's interesting is as soon as I started using this drug and injecting it, if I inject too much, I just stop eating. Like I don't want to eat at all. And that was 20 years ago, probably. And so I thought, this is a very interesting thing. Well, then as the drugs got more available, so that we went from one drug, a GLP drug, to bunches of them, people started to say, well, maybe what if I have pre-diabetes or I don't even have diabetes? Would it help me lose weight? Because I would have less desire to eat. Well, that's kind of what shifting glucagon does for you.
Mhm.
So, um, all of that to say, really, number one, there's a lot of supply, so to speak. There's a lot of variety of these drugs. Number two, we know a little about what they do in the last 20 plus years of having the drugs around, mostly in regard to blood sugar management, but also in regard to how much we eat, which
Mhm.
does relate to your blood sugar. And then when you take the step now to cancer, if you look at, I did a quick, kind of top down review of just things published in the last 12 months on cancer and GLP-1 drugs. And if I was to summarize all the sciencey talk about what they're saying, the first thing is, well, we see an association now, and these are large studies. So, 80 to 170,000 people in different studies. So it's not looking at like five people. So lots of people, half are on GLP-1s, half aren't. They follow them over a long period of time and they see their difference in the number of people that develop cancer. And indeed, the bigger studies show that you have less incidence of cancer almost not universally, but almost universally in people who are on GLP-1 drugs.
Yep.
Now, of course, like all drugs, there's other side effects that, of course, they go into. And there's some thought that there might be one or two cancers that might be more common with GLP-1 drugs, but no one's really sure yet. These are association studies. Now, when you have association study with 100,000 participants, it's meaningful. But then you get down to the mechanisms and the authors, then they get a little bit more cagey and they will say, well, it's we know diabetes and obesity associated cancers are lower, which would make sense because it's a drug that treats that. Um, we know that the mechanisms probably are both through blood sugar control, but also non blood sugar control. And then after that, they say, but we really don't know beyond that, like a deeper level. We're not sure. Like we need to figure out what are the non blood sugar control mechanisms that might help cancer. And the blood sugar control ones, we know a little bit more because of research around other off label drugs, like using other like diabetes drugs,
Metformin and yeah.
like metformin in the world of cancer. Um, so that's kind of the big picture. The other thing is occasionally you'll see a report, and this is another really new paper that just sort of looked at statistics. You'll see a report and saying, well, the longer we follow people on GLP-1s, their overall mortality is higher. And that's an artifact, really, of the fact that the GLP-1 drugs make people live longer. So they're not dying of diabetic complications.
Mhm.
And so they live long enough to die of other things, right? So the mortality increase, at least to the degree we know now, is an artifact of the drug making you live longer than you would with diabetic complications. So when it gets to cancer, I have a feeling because these drugs there's so much money that has gone into the research and development of these drugs. You saw from, let's say, 20 plus years ago till about 5 years ago, they were really just used in diabetes. And then all of a sudden they started to get into the, weight loss market.
Yeah.
And now you take weight loss, huge kind of area of marketing and money.
Mhm.
And then if you get into cancer prevention, that you can 10x the weight loss.
Mhm.
So I have a feeling that on the upside, we're going to find out a lot more about the mechanisms of why these things may work in cancer. I think we'll find out more about who we should be cautious in using them with. But right now, that's kind of the state of the art is we know what they do. We know there's associations with less cancer, and people do live longer because, they're not dying of diabetic complications. The other thing is that, and this is not universal to cancer, but most cancers, anything you do to help regulate blood sugar control and also caloric intake does make you live longer.
Mhm.
So, it's sort of like that fits in there just globally as well. So I have a feeling, we know like this much, like, 5 to 10% of really the whole story.
The mechanism.
Hopefully it keeps turning out to be a positive story because I think more and more people are going to use them.
Yeah, awesome. So just kind of to summarize is we kind of stumbled across the anti-cancer potential of these GLP-1s because of the research done on the populations that they were prescribed for. So the diabetes, then the weight management, and then discovered that if we compare them to people who haven't taken these GLP-1s, they actually have lower incidence of cancer, thought to be because of the blood sugar management problems. I did an episode before on blood sugar management and how it can increase inflammatory signals and growth signals and things like that. So that's why we think that it has these anti-cancer impacts. And my mic might have just went a little bit strange there, but we'll keep going. But that's really interesting. And then, so we have a lot of information. Are people talking now about microdosing? Is there a purpose for microdosing in any of this, or is it more the full impact of the medication dosing that we're looking at?
Mhm. You know, um, I think the short answer is yes, there probably will be a growing, place for microdosing, so to speak. If you look at any drug that is a peptide based drug, so like insulin, for example, or any other thing, some people are really, really like physiologically set up for full dose strategies, et cetera. Some people's receptors are much more responsive, and if you give them a regular dose, they literally may just stop eating, and of course, we don't want that. So there's always a dose adjustment. In my experience with providers who do lots of prescribing here and working with them with patients, it's like any other drug, but with peptide based drugs, if the receptors are real spunky and ready for it, you may not need as much as your neighbor where the receptors have been beat down and they're just not working very well.
And
Same
that's
with
the sugar receptors, you mean?
these are receptor agonists at the glucagon-like peptide, the GLP
Mhm.
moiety. So those receptors, just like your insulin receptors. So insulin is the famous peptide, but everything insulin does, glucagon does the opposite. So it's just as important in our body. So what we have instead of putting insulin in the person is putting a glucagon agonist in the person and balance in the ship out.
Mhm.
Well, just like you can develop type 2 diabetics or insulin resistant, right? That's the most common type of diabetes in the world by way far, and it's based on insulin receptor resistance. The same processes can make you glucagon receptor resistant as well. So if you have that, you would need maybe full dose strategies. If
Mhm.
you don't, you would need lower doses because the receptors are going to be very excited by any amount of GLP that comes along. But that's more of a clinical thing that hopefully is worked out with the provider
Mhm.
who's prescribing it. And I think the other factor with microdosing is, let's say you have, let's say in a future world, right? We figured out why they have an anti-cancer benefit. You as a person have no type 2 diabetes, no pre-diabetes, whatever, but they decide they're going to use it as an anti-cancer strategy. That would most likely be as a microdose, uh,
Mhm.
because your body is ready for it and it doesn't need that much.
Have you seen any clinicians kind of prescribing it for cancer reasons without having the diabetes or weight management side of it? Because I've had some clients come to us and they ask a lot of questions, and some of them are even on it. I've even had anecdotal stories of people like at my training sessions, like my at the gym, say like, "Oh yeah, I'm on it," and they do not need it. Have you seen this kind of popping up just yet in terms of outside of the box usage?
um, yeah, true. There are definitely people on them that probably don't need them. Um,
So
yeah, I think
curious, like what would be the impacts on their body if they potentially didn't have diabetes or weight management needs too?
yeah, I think the real answer is we don't know.
Yeah.
We don't know what giving GLP agonists to somebody that has nothing wrong in that area really would do, other than they're going to eat a lot less. And that may throw other things off downstream, which again, a microdose would be better. As far as have I seen people start to employ it in cancer care? Yes, in the off-label drug or repurposed drug area, but it's probably the newest comer to the party there, and so it's a very, very minor group. I think that group will grow.
Mhm.
I think the place that it will s well, this is my opinion, based on the way they work. I think the place that GLP-1 drugs may start their biggest introduction into cancer care is in what we call secondary prevention. So, primary prevention is let's not get cancer, okay? And then you have two more phases where you have diagnosis and treatment and then recovery from treatment. Then you have secondary prevention, which is you've lived through cancer. You either still have cancer and it's stable, you still have cancer and needs to be aggressively treated, or you have no evidence of disease, remission, something like that. That part of cancer care is getting much more elaborate because we want to keep people either in a long remission or keeping their cancer from coming back.
Yeah, and that's basically what we do in
And
for
that's,
chapter
yeah,
cancer.
so GLP-1s would fit in there, and
Yeah.
probably, I think in our bigger discussion about GLP-1s as a, repurposed off-label type drug for cancer, the tumor microenvironment is the battlefield where it doesn't, all of us, whether we know we have cancer or not, we get cancer cells every day. The tumor microenvironment, regardless of the type of cancer you have, is the place where the interface between your normal cells and your normal immunology that is anti-cancer and pro-cancer forces come together.
Mhm.
Um, so repurposed drugs, many of them, in addition to their primary, on-label, mechanisms, a lot of the repurposed drug families work at the level of the microenvironment, which is to keep you from being pro-cancer. And I could see GLP-1s probably as they work out more of how they work, probably fitting in there. So my guess is we'll see them start to be used in remission or in durable, stable disease, and then they'll probably bloom into other stuff. Yeah.
Yeah. You're actually giving me a really good reason to refer back to I just did an episode as well on the tumor microenvironment inspired by your talk at the AAMP conference in October, I think it was. the
Yeah.
oncology conference. I legitimately took your slides. I'm like, this is amazing. Everyone needs to learn about this because this is all about what recurrence prevention is changing that tumor microenvironment to be
Right.
more anti-cancer, more pro-cancer, and people need to understand that's how everything works basically that we do.
Yeah, it's
Yep.
well, thank you for doing that, by the way. We need more people talking about it. And it is kind of like we've always known that there's something there, but the science has just blown up around
Yeah.
understanding it.
Mhm.
I'm doing the next level of that talk at the Oncology Association meeting next month,
Awesome.
and looking at comparing solid tumors and blood cancers and their microenvironments. But that if you can get to that level of helping somebody in treatment, you can head off the macro problems that we can wind up with. And so I think I see personally, just knowing a lot about that, a lot of our repurposed drugs are probably more working there, than other
Yes.
places.
Then and they're not exactly killing cancer cells necessarily. They're
Right.
triggering your body to be able
Yeah.
to either or not cause cancer, to basically tackle any precancer cells to not be there or get to fixed, or to kill off the cancer cells themselves. It's working with your immune system and everything else for sure. Yeah.
Yeah. Yeah. And some may open the door to cell killing, but
Yes. Yeah.
most of them are there to work on the terrain to be anti-cancer, and then your
Mhm.
body
Yeah.
your body or the other treatments can take over.
Yeah, yeah. So just to kinda say, like, that small group of practitioners and people that we're seeing who are looking into microdosing or to taking GLP-1 specifically for cancer, they're kinda starting to open the doors as well for looking into, more studies for doing this kinda stuff. There's the research maybe isn't quite there yet exactly for secondary prevention, so preventing a recurrence. When it comes to these medications, the potential is there, but as clinicians, it's hard to say, "Yes, it's safe, you should take this is how effective it is," because we don't exactly have those numbers yet. Is that correct? What I'm hearing?
Yeah,
Yeah.
certainly. Yeah. Yeah. I mean, I think in a cancer patient, the same clinical management would be used for adjusting dosing as you would in a diabetic patient, for
Yep.
example.
Mhm.
But we're not like we're nowhere near the place where we can say, oh, this is most likely going to help these cancers because of these reasons, and here's how to dose it, and don't use it in these. We're not there yet.
Yeah.
We've got really nice outcome studies of large groups of people who didn't take it, and we have longer life and less cancer, so that's great.
Mhm.
The part between we know how it works for diabetes and why did people live longer and get cancer stuff, we only know little bits and pieces. Yeah.
And there's also a difference between someone who had these medical conditions and required a treatment versus people who may not have had those medical conditions, but are still interested in using these medications for cancer reasons. Like if we're treating someone with diabetes, they already have like a 30% increased risk of getting cancer in the first place. Whereas if we're looking at people who don't have diabetes, but they are still interested in these medications, is a different impact on the body. Yeah. Yeah. Okay.
Yeah, and that certainly affects the numbers and the stats and the outcome.
Mhm.
Because if you take a population, which is what all the studies do, that has 30% more likelihood of cancer, you're going to see a much bigger effect,
Yeah.
which is great for them. Would that happen in a non-diabetic person is a really open question.
Yeah. So there's a bit of relevance that we want people to pay attention to when it comes to the population being studied, and is that actually you in terms of if it will be effective or
Right.
not?
Right.
Yeah. And then the last thing I want to touch on before we go into antiparasitics, which will have kind of a very similar conversation, I think, is what are some of the side effects of GLP-1s that people need to be aware of or watch out for?
Yeah, I think, there's, there's long lists, but I think the major ones, um, the more people that we see on GLP-1 drugs, the more you can see gallbladder oriented issues. Some of that comes from just the mechanical fact that if you really restrict, the drug makes you not want to eat, etc. So you're really lowering your caloric intake, which has good outcome.
Mhm.
But if you get your fatty acids in your diet too low, when your body is going to make bile, which is what comes from your gallbladder to help you digest fats,
Mhm.
it's largely made from fat metabolism. So what we see in people, and you can do this without GLP-1s too, but if you really lower your fat, the bile gets thicker and more inflamed. So the system is made to sort of work with bile that moves quickly. People on GLP-1s can get kind of real, they actually call it sludge, thick bile
Bile sludge,
that's
yeah.
really inflamed. So they get, upper right quadrant or right shoulder pain and, kind of angry gallbladders and stuff like that.
Mhm.
So that's one. So the big like nausea and vomiting are the major side effects. That's because of a couple of things. One is this bile thing, which I think we're going to see more of. And the other, though, with nausea and vomiting is it does slow down your digestive tract. So people can get, if you slow your stomach from working, uh, stuff sits there longer. And the longer it sits there, the more you want to throw up. That's your body's natural response. So nausea is really common. Constipation's at the other end of slow bowels. It That's another one that, kind of comes along. Interestingly, even though it slows down the transit time, some people get diarrhea instead of constipation.
Yeah.
And it's thought that might be more of a microbiome shift that's going on with things just sitting too long. You grow the wrong microbiome and then you get diarrhea from that.
Mhm.
That's a theory. Um, those tend to be the big ones. Now, if people overdo it, not only will you eat too little, if you are not actively doing something to work out on GLP-1s, you will lose muscle mass.
Mhm.
So one of the things, about um, there might be people in your audience old enough to remember this commercial where someone says you don't fool Mother Nature, and I think it was maybe a butter commercial or something. But anyway, it was a long time ago. Anytime you start to go in and mess with receptors that are supposed to work due to normal feedback, if you do too much of that, your body will respond in some way because it doesn't know why you're doing that.
Mhm.
Now, if you have diabetes, it's a little easier because you're making the system better. If you're doing it just for weight loss and you have no insulin sensitivity problems or any of that, that's again where microdosing can be much better and where your clinician's going to have to really keep track of these side effects and say, "Wait, you might be doing too much, or you may need to kick up your workouts and your protein intake to balance this out, keep your muscle, metabolism going." Um, and then the other thing, just the things that normally happen if we restrict food, you could get nutrient deficiencies depending on how good you're balancing the food you are eating, and things related to that.
Mhm. Yeah. And one of the main things we see post-treatment, especially in the people who kind of seek out our support, is like they're often a little bit malnourished. One, because treatment can be pretty harsh. Two, they're also very afraid of what to eat. And I honestly just don't think we're doing enough exercise in the real life anyway. So a lot of people are already a little bit lower on their muscle mass. So we do want to be cautious that if people are on these medications, that they know that their appetite is gonna change, their nutrient deficiencies might increase, and then, the muscle mass, I think, is the most important thing because also with more advanced cancers in particular, we're looking at cachexia, and if we're combining cachexia with the muscle mass being decreased on these GLP-1s, that's a really bad mix overall, so just a little caution out there. There are ways to support the body, though, but yeah. What were you gonna say?
Yeah, no, I think, um, yeah, you have to be, everything has to have a balance, especially, I mean, with regular cancer drugs, let alone,
Yes.
repurpose things. And so if you have uh, a process you're trying to avoid being cancer, and later cancer, you have cachexia develop because of the cancer metabolism, we're not trying to mimic cachexia on the prevention end. We're trying to get you healthy, but not cachexic. And I do think, I mean, you probably see this also. There are people overdoing it, with GLP-1s, and they're not as well managed. And then they do start to lose muscle mass and protein. And muscle mass is directly related to cancer prevention, but also survivability of cancer. So, yeah, I think if people are on GLP-1s, in addition to taking care of their GI tract and their macronutrients and micro, which are huge, they have to remember they've got to keep the muscles working and keep their muscle mass up. And that's the best hedge against most of the side effects.
Agreed. Yeah, and because your bone mass gets impacted that way too when you
Right.
lose muscles.
Right.
It's super important. Yeah.
Yeah.
Mhm.
Yeah.
Okay.
And
And
just to say, we much longer history with it. People who did bariatric surgery or do bariatric surgery, we see exact same problems just for mechanical means. They can't get enough macro and micronutrients and they become profoundly deficient, and so you don't want to do that with a chemical treatment either.
yeah, like with everything, there's a trade-off. You get your pros, you get your cons, and the cons can often be managed. They just have to be you have to be make sure that we're on top of it as clinicians and even clients. Like you have a responsibility as well to make sure that you're in tune with your own bodies and kind of taking these, I don't know, these opportunities to strengthen and take some ownership over your health too. So very important stuff. And then leading into the antiparasitic side, it's kind of the same deal where we're looking at managing the microenvironment, basically the tumor microenvironment. That's what we're looking for whenever it comes to these antiparasitics. So different mechanisms. So why don't we jump into those? People come to me about ivermectin, or I get messages on YouTube and Instagram about ivermectin, fenbendazole, mebendazole. I can never say that one right. Do you want to jump into that and potentially what are their mechanisms of actions and how they might help someone or not help someone, help someone?
Yeah. So the 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 world of repurposed cancer medications or off-label um, is actually a very broad amount of drugs. So we talked about metformin, for example, diabetes drug and related compounds that are used. Um, Metformin was sort of the first one in the standard oncology world to get notice, and for basically the same reasons as GLP-1 drugs. It was just 30 years ago. And it was like, oh, this not only did metformin help the person with diabetes, but the people on it had less cancer. So we should look into that, right? Um, so the first thing you want to think about with repurposed drugs is there are multiple categories. So there's the antiparasitics that are the most famous and hot right now that we'll talk about. There are the anti-diabetes drugs, kind of touched on those. Uh, there are drugs such as certain blood pressure medications can be anti-cancer, certain antiviral drugs, statins for cholesterol can be anti-cancer. And then in addition to the antiparasitics, um, there's a number of antifungal drugs. I mentioned antivirals and also plain old antibiotic
Mhm.
uh, can be very anti-cancer in certain situations. So I think the first thing, and just for background, so as compared with GLP-1 drugs, where I was teaching about them, teach doctors how to use them 20 years ago, 25 plus years ago, I started using repurposed drugs for cancer. And at that time, it was mostly metformin and antiparasitic drugs, and then a few other dibs and drabs. Now the menu is much, much broader. So I've been doing this way before it was cool,
Yep.
before social media. Uh, so what's interesting is we used to say now I'll just talk about the antiparasitics so we don't have an 8-hour window
I
to
know,
talk
right?
about
I
the other
wish.
drugs. But just so people know, like lots of other drugs can be used in cancer
And I
treatment.
know you've talked about them a lot on your YouTube channel too, so we'll definitely be referring people over there. Yeah.
Yeah, we do. Those are popular over on
Okay.
the on the YouTube side. Um, so, but if we now narrow down to like the antiparasitics, which was one of the first ones we started using many, many years ago, um, we used to say, because we didn't really have a ton of science around there, well, why would they work, right? Um, we used to say, well, it's probably has nothing to do with the antiparasitic part, but there's probably like a tumor cell biochemistry manipulation or something like that. We would come up with these things, and then there would be science to show, well, it might help the immune system have an opening to start to kill the cancer cell, or it might make the cancer cell more open to an anti-cancer drug or whatever, right? And what's been interesting and also just amusing to me because you do it long enough and you see all these sides, is there the antiparasitic mechanism actually now in the science is a thing. And so, and I've got a long YouTube on this, but basically the punchline is it's not always that, say, a parasite caused your cancer and we have to kill the parasite,
Hmm.
but that does happen.
Hmm.
Okay. So for years, people would say that it has nothing to do with the antiparasitic mechanism. Actually, it does. And if you look at the science that we have now, solid tumors harbor parasites and fungus and other nasties. And so the thing is, you never know what caused what. But if you lower the number of things that could be, stoking the fire of the cancer, the the fire gets lower, the cancer gets easier to treat. And the cool thing with the antiparasitic class, especially, is they are both sensitizing the cancer to treatment, improving the tumor microenvironment milieu, so it's more anti-cancer, and they're lowering whatever critters are around that may be stoking the fire of the cancer. You can never tell which you're doing more of, but any drug that does more than one thing, it's always that way. Couple of things. So there is a category which you mentioned a couple of called the benzimidazole drugs. Those are antiparasitic drugs, and they started with mebendazole and then albendazole. Those are the two human drugs for parasites. And then for animals in the US and Canada, there is fenbendazole. Now, Fenben has a huge internet following. It's very big on the
More
internet.
popular than me. Yeah.
That's right. You can go down to the pet store and buy all you want and all of that. Um, what I always tell people is, and every time, and I don't spend my whole. I've got a lot of stuff in my life, but I do look at what people are putting on social media because so much of it around cancer is misinformation, which is not great. When it comes to fenbendazole, there will be people who have legitimate, reason to know stuff, good credentials, and they'll say, well, fenbendazole is the only benzimidazole that does this thing for cancer. And it'll be some pathway manipulation. And I'll think, I don't think that's true, but I'll go look.
Mhm.
And there's nothing that fenbendazole does that mebendazole and albendazole don't do.
Mhm.
And if you look, and so it's not, I'm not like saying fenbendazole is bad. It's just, it's a cousin of the other two. And, for you and me, if we recommend, it's actually illegal for us to recommend it because it's a veterinary drug, right?
Yeah.
And our patients are human. So I always make sure I tell people that, and it's in the chart. Uh, the other thing, though, is that until we figure out fenbendazole and it would become a human drug, there's a lot of things around dosing and safety that are not known as well.
Mhm.
Again, mebendazole and then later albendazole, I've used for over 20 years. Those are predictable. They've been human drugs, etc. So I tend to use those, but really that whole class works in a similar way. What I will say though is if you look now, just like antibiotics, antiparasitics come in different chemical classes. So benzimidazoles like mebendazole, albendazole, fenbendazole, great stuff. They work sort of in their own way. And then if you look at another class called the Ivermectin class, that includes ivermectin, that would make sense,
Mhm.
but also includes a bunch of drugs that we don't have here in the United States that are only used for cancer in other parts of the world.
I didn't know that. Yeah.
Yeah, it's well, that's true. That's the benefit of being a retired pharmacology professor. So the thing I used to say I'm a recovering
Mhm.
pharmacology professor. Um, but the thing about it is, and I didn't really put two and two together until many years ago. I was with a colleague who is another outside the box medical doctor, and he says, yeah, I started to work at a hospital in a foreign country. And I was doing the same thing, just a different foreign country. And I said, what are you doing there? And he says, well, there's this Ivermectin drug that we can get there that we can't get in the US. And it's used not for parasites, but for cancer. And it was a really effective and relatively safe chemo. So in this country, the main one we can get is ivermectin, which again, prior to COVID, nobody even heard about it. Like we
Yeah.
used to use it for cancer and parasites and stuff, but wasn't a big deal. Used to be, 3 cents a pill. Now it's $1 or more. So ivermectin works through other pathways than the benzimidazoles. So usually when I'm using them, I don't use one if we need to. I usually try and use two or three at the very least,
Mhm.
partly because tolerability to humans of ivermectin and the other ivermectin, but in US ivermectin is a very broad, it's a very forgiving drug. Okay. The benzimidazoles are not very forgiving.
Mhm.
And you often have to rotate the dosing with them, or people can develop peripheral neuropathies and other, things like you would see with maybe some chemotherapy agents. The upside is if you rotate them for the tolerance of the patient, they still work, right?
Mhm.
Because if we think about it, like the benzimidazoles, they're like like a big giant hammer in the antimicrobial world. They're only meant to be used normally for a short period of time, and you kill whatever creatures you're killing.
You didn't.
In cancer use, you using it longer term, so we usually modulate the dose. And why I like to use more than one category is I can use lower doses of all of them and improve
Yeah.
the
The
safety profile
cumulative impact basically on multiple pathways, lower doses. Yeah.
and
And
surround the microenvironment and surround the tumor from different angles.
mhm.
And then the other thing that I do, and I can't remember a time I haven't done it, but I'm sure I did once. But I normally do. I always have some sort of botanical that is liver supportive. Usually I use milk thistle because it's also a chemosensitizer, but you can use other stuff. And that really helps as well. Like that makes the tolerance for these things better.
Mhm.
So if you look in um, human nature, always wants the simplest answer, and in anything in health, but especially cancer, there's no simple answers. Uh, So usually what we wind up doing that works better is lower doses of multiple agents and usually two antiparasitics from different families and then one or two others like let's say metformin or somebody else in there, depending on the type of cancer. Uh, and we'll use that. And then the ones that are a little spicier and harder on the system, we will rotate so that the person kind of has a on and off cycle, let their liver breathe a little bit. Um, you can do them daily for a while in a cancer patient till you get things looking better. But the real long-term folks, like if someone's got, like we talked about GLP-1s and secondary prevention,
Yeah.
um, same with these. They can be used at lower, longer-term dosing. And then, because we don't want to give people the side effects,
Yeah.
basically.
Makes sense. So just to kind of summarize that is there's both an actual potential anti-parasite killing aspect to helping to block cancer but the main or one of the main places that these antiparasitics come into place is by the tumor microenvironment. Again, just kind of setting up the body to be able to be more anti-cancer in its own way while we're not feeding the cancer and we're also creating a stronger immune defense or whatever pathways, and it hits a whole bunch of them. And then there's different categories of medications that have different impacts on that tumor microenvironment, potentially even hitting different types of parasites or whatever might be in the tumor as well. And that's how we're having a kind of full picture cancer mitigating impact in the long run, which is great. And then again, a lot of our people, they are still in treatment or they're just finishing treatment or they're done treatment, but there's a place for all of this. But after treatment, we're kind of looking at would you consider like cyclical dosing, like come on and off of it, or is it like would you prescribe it to someone who had just finished treatment, or what if they were 5 years out? Like when would be the ideal dosing or ideal initiation of treatment for someone who had just finished cancer treatment?
Yeah, there is a difference between the intensity of dosing if you're using it alongside their regular cancer treatment when in the active phase versus after. And so after could mean they're on a maintenance chemo or something because the cancer's there, but want to keep a lid on it.
Mhm.
Or it could mean there's no evidence of disease, but you never know, so we want to keep a lid on it.
Yeah.
Um, what I normally do once we get to after acute treatment phase and they're near or in secondary prevention, some of the drugs uh, would not be rotated.
Mhm.
Okay. Those tend to be the other classes. So that might be if we're using metformin or if we're using a statin, or in some cases, if we're using one of the receptor mediators like the blood pressure drugs or something. Those might be at low dose, kind of long and slow. The others, especially when you get to the antibiotic and antiparasitic and then antifungal as well, um, my personal experience has been once we're done with the acute killing phase and we want maintenance, I will rotate them and it will be usually 3 or 4 days a week where they take the drug and then they will have the rest of the week off, whatever. So if they get 3 days of drug, they get 4 days off. And they're going to be taking something for their liver health and all of that. And what we find is that that's much better tolerated. We get a lot less liver inflammation, liver enzymes going up and stuff, and you still get the benefit. Now, what people will do, let's say, just to make up something, but a common thing, secondary prevention, where we really don't want to let our foot off the gas too much. We want intense treatment. We might do, say, 3 days of the benzimidazole, like the albendazole or mebendazole, and we might do 4 days, the other 4 days when they take their ivermectin. So there may be some drug going in all the time.
Mhm.
And then say if they were on metformin, which many of them would be, that'd be every day. So it's sort of like that for most people. If it would be the rare person, unless they were just super tolerant and had a real aggressive cancer, where you would be able to leave them on a benzimidazole daily forever and ever, because they're just hard to metabolize.
Fair enough. Yeah. We don't do any prescribing of medications ourselves. It's just not within my scope of practice. Mainly, we're kind of working on the tumor microenvironment in different ways with nutrition and exercise and supplementation and optimizing people's blood work and stuff like that. Um, which I think you're under the same. I might be putting words in your mouth, but I don't think so because I've been attending enough of your training. You're under the same impression that like a lot of these drugs work way better whenever you do all of the harder stuff in a way where you do the lifestyle nutrition things too, right?
Exactly. I think, and that's a really good point. And it's the same point we made briefly with GLP-1 drugs. They work the best, as do all these other drugs, in the setting of a body that's being taken care of.
Mhm.
And as you mentioned, the harder part, uh, keeping the person doing some kind of movement to keep their muscles working. Having a person with cancer, you don't want too much protein, but you don't want too little protein either. You need appropriate protein, you need
Yeah.
appropriate fats. And so their body can stay healthy because a healthy physical body, especially muscle mass and blood sugar control, is a body that will live longer with cancer and is a body that will resist cancer better.
Mhm.
So, those things, but those are, as you and I both know, those are the harder things to work on
They really
people
are.
because it involves all the rest of the stuff. And
Mhm.
then there's other things such as, again, kind of like the protein story, you don't want too much antioxidant activity, but you don't want too little either. You have to keep it modulated for the patient because the microenvironment's really sensitive to that. And one of the reasons why things like toxicants and infections and other nasties that, are we're all bathing in all the time trigger cancer is just because they're pro-inflammatory. And then the microenvironment says, oh, well, there's those pro-inflammatory signals. and then a neighboring, cancer stem cell says, "Oh, that's for me," and takes off. So it really is like, um, when I do trainings about repurposed or off-label drugs, it's like that's great. It's a tool, or there are tools that we put into combo. But if you're not doing all the other stuff to help so that their diet does the right thing for their body, including insulin and glucagon and all that, and their muscles are getting some kind of stimulation, in their brain and their mind body are doing something, those drugs are going to work and then they're going to stop working
Yeah.
because they're not going into a system that's optimized for them.
Not ready to receive it or something. Yeah. Yeah. And I think that's just, I want to just kind of point that out because again, it's the Instagram messages I get that are more like, I'm taking this drug and this drug. What else should I be taking? And I really just want to talk about what are you eating? How much are
Right.
you
Yeah.
exercising? Like, have you had your blood work done a little bit more comprehensively? So just a little caveat to the listeners that we're always
Yeah.
back to lifestyle and nutrition stuff too. So
Yeah. It's the base is as or more important than every other treatment. And, you know, and it's frustrating, I think. I mean, some patients are already, they know that, but it's frustrating for people because, again, human nature would be, it'd be great if there was a pill that would do this for me instead of, oh gosh, I got to watch what I eat and I've got to do this. you know,
or even if
it,
society were a little bit easier to
it,
navigate in terms
yeah,
of fast food that wasn't gonna give you a bunch of grease. Yeah,
right.
it's
Yeah.
nice,
Yeah.
yeah.
Yeah. Grease and chemicals together, the perfect storm.
Yep.
Yeah, yeah. So I think that's a really critical thing. And I know in the patients I work with, and then in the people that I mentor who are working with patients, another big thing though is to not make it like the person has to fall off a cliff and be perfect at everything.
Absolutely.
Because you start with where you are as a person, and with getting the muscles moving. I've had people that said, "Look, I had surgery. I was in the hospital getting chemo, and now I feel not like working out at all." And it's like, okay, we're going to start with you don't want to do anything, and we're going to do a little more than that, and we're going to do a little more. And same with your diet. We're gonna look at what just junk can we take out first, and then what good sources of protein can you have that are going to work, and so they don't feel defeated, like oh, I could never achieve that, because we certainly see that a lot with people. And I think people don't really understand that baby steps can make huge differences in these things.
Absolutely.
And
Yeah,
that's why you and I exist, I guess. So,
I think so.
yes. Yeah.
So just I guess the summary here is that the drugs are all very important. They have amazing impacts. They do have some side effects that we want to be cautious of as well, but foundation first, and then kind of adding these things in as we start to build and build. And your plan might take a year to get to you to where you thought you would want to be in a month, but that's okay. You're still adding bits and pieces to being anti-cancer every day, or at least every second day if you're only able to do it every second day. And eventually you will get there and every bit counts. So very
Yeah.
important stuff. Yeah. Anything else that you wanted to, that we didn't talk about yet that you wanted to mention on these medications before we hop off?
Um, I think in and again, this used to be very rare that people would be able to get access to drugs without going, through a healthcare provider. And now you can kind of get whatever you want. It appears. Um, so just a couple of cautions there.
Used to, yes.
One is, you still let's say you have the best, purest form of whatever the off-label drug is, let's say, and you're using it. So, there's no worry, and it's dosed correctly. You still need to go somewhere, and you still need to have monitoring labs done. We need to keep an eye on your blood counts, and you keep an eye on your blood chemistries and your liver, kidney functions, because those can be affected, especially by some of these combinations, especially if you have cancer. Then you also need to keep an eye on things like your hemoglobin A1C and your overall blood sugar control and other related, inflammatory markers and stuff.
Liver
So
function. Yeah.
regardless of where you're obtaining all the treatment, you're getting that sort of macro look at your health. You need to, the more stuff you're on, meaning the more drugs you're on, the more frequently you need to monitor, kind of how it's affecting your body. But the other side of it, and unfortunately, I've seen this happen, is with the availability of just ordering XYZ medication online, not all sources are going to give you the medication that they say they are, and there's no regulation over that. Um, and then sometimes you're getting the medication, but you're also getting a bunch of other stuff in it that you don't know about and you don't want. There are some suppliers around the world that will ship anything to you, and some of their product is full, for example, of heavy metals or other, tainted with other drugs, et cetera. And I know of a number of cases, but I know of a case just a year ago where unfortunately that hastened the demise of the person because they just thought, well, I can buy this in bulk from another country, and they certainly could, but it turned out that they were getting more than what they were, what was on the label. So I'd just be very, very careful with sourcing things. I mean, even sourced appropriately through normal channels, sometimes stuff goes wrong, but you don't know if you're able to buy a drug that is, controlled under Health Canada or the FDA without a prescription when you normally need it. There's a layer of a question mark there. So just be very careful. If you are going to do it, to have someone check it out, and make sure you're working with someone that can do, your labs and check in with you and adjust things. So that you can take care of your whole body.
Yeah. Yeah. For off-label medications right now, we're kind of in between where we have an idea that it could be anti-cancer, but we don't have the evidence yet, which makes it hard to prescribe it and get it prescribed. Yeah. So you're left kind of navigating everything from language barriers, because it might not even be an English label on whatever you're purchasing, to might be the wrong dose in the actual pill, might even be a different form than what you think you're getting. And then again, if you're going to comment on that?
Yeah. 100%. Yeah. Maybe because one name of a drug can come in more than one actual biological form. And the other thing too, which I think it's a positive because it means people are doing research, but if you look just at that mebendazole, the sort of original benzimidazole, there's research going on at doses that are kind of what we've always used. And then there's research going on at super high doses. Not to say either is the right way to go, but what it says is they're still trying to figure out how much does it take to affect this kind of tumor. So right now we're working with incomplete data. We're working with our experience with these things. And it is frustrating because let's say you wanted it from a real legit source and no one will prescribe it for you. Of course, you may have to go elsewhere, but just, buyer beware, keep all these things in mind and work with someone like you to keep track of the rest of the stuff.
The labs are important too, for sure. Yeah. Awesome. Well, thank you very, very much. I think this is super helpful. I'm definitely sending this episode out to everyone who messages me on Instagram now. It's kind of a selfish reason I did this episode, I would say. And thank you again for all of the educational pieces you provide for all of the providers out there, as well as clinicians. Like, that's kind of your main thing. But if you are someone who's just hanging out and you're looking for information for yourself as a client, check out his YouTube sources here. So it's www.youtube.com/@DrA-online. There's a bunch of short videos and long videos on pretty much anything you can imagine that is cancer related. And also he has amazing books. Highly, highly recommend checking them out. I think you can get them pretty much anywhere, Amazon, everywhere. But the website would probably be the easiest place to find it, which would be dranow.com. Again, we'll put it all into the show notes. And that's it. Thank you so much. And I hope everyone enjoys their day. Thanks.
Thank you.
Thank you so much for joining me today on the Flourish After Cancer podcast. If you loved this episode, please be sure to leave a review and subscribe so you never miss an episode. Sending all my best your way, Dr. Megan.